context from either the national context or from an Oregon context of about expired naloxone because that was a project that we were all interested in pursuing. So we're going to do roll call up front, then I will pass it over to Dr. Stater and the naloxone project. And then we will go into director's updates, and at the end, we will hear from Dr. Sarah Present. We'll do some discussion in the middle. So a little bit wonky today, but I think we will, it'll all make sense in context. So, um, Ashley, would you like to pull up roll call?
Yeah, good morning, everybody. We're going to run through roll call really quick. So, Stacy, are you here?
Here.
Dharma,
Here.
Blue,
Here.
Mariah,
Here.
Eric,
I'm here.
good morning. Haven,
Here.
Jenna, Adam Cabot,
Here.
Scott,
Here, present.
Serafina,
Here. Present. Good morning.
good morning, and Crescencia. Okay, and Mara, we have reached quorum.
Amazing. We don't have anything to vote on today, but thanks for letting me know. I was worried that we weren't going to have that many folks with us this morning. Stacy, would you like to do an intro for Dr. Stater? Oh,
Hi, can you guys hear me?
yeah.
Okay. I'm just going to apologize ahead of time. I'm home. I just left my position at Care Oregon, so I have a little bit of transition happening right now, and I also have a sick teenager running around the house. So I'll be moving around, and I apologize for for it not being as smooth as normal. Dr. Stater, are you on the call?
Hi, friends. How you doing?
Hello. Nice to see you. Thank you so much for joining us. This is the ADPC Health and Safety Committee, as you know, and we're excited to hear about your naloxone work. I'll let you take it over now if you're comfortable.
Yeah, sounds great. Sounds great,
Thanks.
friends. Well, I recognize a few people, I think, for the first time I chatted with Oregon. And for those that don't know, my name's Don Stater. I'm an addiction and emergency medicine physician, and I'm the executive director of the Naloxone Project. The Naloxone Project is a nonprofit started in Colorado, but currently in 15 states and growing, that really is committed to addressing the overdose crisis through evidence-based naloxone distribution. And we work on almost everything naloxone. So we like to say we're a bunch of super nerds who really want to do good and get naloxone into hands in the most sustainable, cost-effective, and intelligent way possible. And I think one of the things that I was invited to speak about the most is kind of the interest around expired naloxone and a regulatory and legal framework for distributing expired naloxone in states. And I have a small presentation about that, if that's okay. Okay, great.
We're thrilled to have you. Thank you so much.
Yeah.
And I love this idea of a super nerd. This is great. This is our favorite kind. So go ahead.
Oh, yes, yes. I readily and lovingly take this on. So let's see here. Well, I'm supposed to be able to present this in a sexy way, but I apologize. I'm just going to scroll through this, okay? So first of all, the Naloxone Project is in strong support after reviewing the evidence and the practice of building systems where expired naloxone can be part of our naloxone strategy and our overdose strategy. And we think that it makes a lot of sense, both from a safety and evidence perspective, but then especially for a cost perspective, as different states look at likely decreasing Medicaid reimbursements from the federal government, and two, how to deliver these services as equitably and as expansively as we know is required to address the overdose crisis completely. So the evidence, there's a decent amount of it, right? That says that naloxone is safe far, far after and effective far, far after it expires, right? And I like to also mention that like a lot of this has to do with how the FDA approves drugs, right? So when you actually apply for a drug to be approved by the FDA, who proves how long it is good for is actually the manufacturer of the drug. So if I have a new blockbuster drug that I bring and say the FDA, I would like to show you all my safety data, I'd like to show you the effectiveness data, and I'd like to show you the expiration data. The FDA takes all of that from the manufacturer. But then oftentimes the sweet spot for drug manufacturers for how long they want their medications approved for is between 2 and 3 years. So after that, typically manufacturers stop submitting safety data for when a medication expires. And it makes a lot of sense because if I am Don, the manufacturer of whatever medication, right? I would like after 3 years people to buy another round of my medication. So the financial incentives are very much there for manufacturers to say, I want an expiration date that makes it seem reasonable and that they're not returning lots of drugs to me, but also one that's short enough that people will repeat a buy. So what you find is for most drugs, after a certain point, you stop getting evidence about how good they're still good for, right? And really taking the milk carton analysis of like, yeah, how do you tell? Have you ever drank milk that's a little bit past date, right? Or eaten food a little past date? Because you take it out and you smell it and you say, is this still good? Well, when you do the smell test for naloxone, guess what? It's good for up to 30 years after it's expired. And we know that because we study the stability of the molecule and see how much of the active molecule is still present in vials, et cetera, of naloxone. And that includes sometimes naloxone that is stored in suboptimal conditions, not the 70 to 80 degrees that is recommended by the manufacturer. So this appreciation that naloxone really is very stable, that it does not expire, and that is still extremely effective, sometimes decades after expiration, has led the naloxone project to really suggest that we actually acknowledge that scientific reality, and then in the midst of an overdose crisis, how to figure out how to get naloxone out, including expired naloxone, to people who might be at risk of overdose. So we also know that that expired naloxone can help us fill funding gaps. And I'll say personally, as a nonprofit, one of the things we noticed once we had an expired naloxone bill is that we started getting lots of donations of either expired naloxone products or very, very short dated products, which were going to expire in the next 6 months, right? And for most people, they'd say, oh, well, 6 months, then I need to throw this away. But we said, oh, 6 months, we have a bill, we have a framework to get this out. We can keep expired naloxone and continue to give it out as our populations need and as our clients need. So it's been a very big benefit to us. Now, one of the things that Naloxone Project specializes in is we do a lot of healthcare related distribution. And one of the things we've just got, and this is pretty hot off the press, I think you're only the second or third group we've shared this with, is that Joint Commission, when you have a law that has statutes saying you can distribute expired naloxone, including through hospitals and medical spaces, Joint Commission, who certifies most of the hospitals in the country, says that is actually not a violation of Joint Commission policy. So they have policy on you can't distribute or use expired medications. And what they've said is we have a carve out for naloxone if your state has a law. So very, very important here. If part of Oregon's naloxone distribution strategy is not only harm reduction facilities, but let's say EMS providers, medical providers, and hospitals, all of which we believe are very well positioned to serve patients at risk of overdose and with opioid use and other substance use disorders. This little bill, I remember too. This was an add-on that like I do a lot of work with the Colorado legislature, and this was an add-on I got for a bill like 2 or 3 years ago. I was like, hey, have you seen the evidence of expired naloxone? If we wanted to distribute more of this, I'd actually just like legal protections for it. So we wrote just a few sentences into this bill that got passed unanimously in Colorado House, and it's been amazing that of a lot of the bills that we've worked on, this has been the one that's grown the most legs. Um, and it's because it's a good idea that makes a lot of fiscal sense. And I think that it's started to just go across the country, including to red states, to blue states, to purple states, right? Where we have naloxone expiration bills now passed in multiple states and multiple states considering naloxone expiration bills. The most recent bill to pass was actually in Kansas, right? So again, this is a bipartisan issue where I think it just makes common sense, and we want people to have access to overdose antidotes. Okay, I know most of this was going to be Q&A, but I thought we'd just give a little bit of the background for that. We're also happy to share any legislation, practice, etc., and happy to talk about any other aspects of naloxone distribution, overdose prevention, just so that we make good use of your time.
Thank you, Dr. Sater. Well, first, we're wanting to make sure that we get slides. So it looks like we're going to get that figured out. Thank you, Nikki, for sending those to Mara. I think we can open it up to the group to see if there are any specific questions for Dr. Stater. Does anyone have any on the top of their head, off the top of their head, questions to ask? Go ahead, Serafina.
Dr. Stater, thank you so much for being here and for the work that you do. It means so much. One thing that's coming up for me around the expired naloxone, and as that bill was passed, receiving a lot more donations from the community and understanding, I guess, that I know even expired naloxone, and as you talked about, naloxone that's been through different temperature changes is still effective. But one concern that we had in giving that naloxone back out to people is, how exposed has it been? Are there any laws around giving that out? And I'm sure each state is unique, but what was your experience around that?
So we recommend that you give the same statutory protections that you do to any other naloxone usage, right? And distribution. So if your state has a great Good Samaritan law for both the person using the naloxone and the well-intended organization giving it out, then our ask is that you just extend those to expired naloxone products, right? And our experience has been very, very beneficial. Here in Colorado, we have dozens of hospitals that give these out to very sensitive populations, out of emergency departments, etc. And the ethics of it, if you want to ask what are the ethics, is we actually label all our naloxone as expired and provide patients with the information that expired naloxone is still effective and the evidence. And we also allow them, if they are uncomfortable with it, to seek non-expired naloxone, either through the over-the-counter options, or if a facility does have both products, I think it's totally reasonable for patients to be able to request, a non-expired product. But for many of ours, what we do is this is done as a public good and not as a revenue generating service. So many of our hospitals that distribute only have expired naloxone, but are very happy to, again, point people to other community access points of non-expired product.
Go ahead, Blue.
I just wanted to ask about that Joint Commission letter. Is that something that's public now, or is it going to be published soon?
We have that letter and we're happy to share it. We are figuring out how to best share it with some of the states that we're working with and partners that we're working with. But yes, that's our intention, is to, to distribute this so that we can reassure, states. And the only thing that I think is a caveat is we don't want to show this letter to a state that then thinks, oh, Joint Commission is okay with expired naloxone, in a state that does not have the regulatory and statutory protections that other states have provided, right? So I would hate for, the state of Hawaii that doesn't have a bill to say, oh, we can give this out now. And then if there's a bad outcome, for them to then have medical legal risk associated with that And also that would be misrepresenting the thing that Joint Commission has given us this kind of narrow exception for, right? But we're very happy to share that letter, yeah, with those caveats. Nikki, I'm assuming you're taking notes and can ship this out after to everyone. Okay, beautiful.
The meeting's also recorded. If that's helpful, we'll be able to go back. Any other questions? I actually have a quick question if no one else. It sounds like you've really leveraged hospitals to move maybe like larger quantities of expired naloxone, which is it sounds like a really great approach. How, and maybe this is too much in the weeds, but are they how are they documenting the process of handing out naloxone? Because I'm assuming there's no like claim, so they can't maybe do it the typical way. So any thoughts on that?
Yeah, so typically they are documenting it through an order, an EMR order, and we collect data on all of that, right? Because we wanna know how much naloxone is being given out in different states. And really, I think there's two things that when I talk with systems about it, it's one, you have to have the ability to actually do it, right? So we have the naloxone stocked, we have a way to get it out, we have an order we can put in. And then the second thing is a quality improvement question, that falls much more into PDSA and all that stuff, is like, how good are you doing in addressing the needs of the population that we aspire to serve? And for that, the Naloxone Project works with states and hospitals to develop a batting average of this is how much your emergency department or labor and delivery unit or other things sees of patients who are at risk of overdose. Here's how much naloxone you should be giving out. And then are you actually correctly identifying and distributing those? Or are there people that you miss? And for us, when we've done some of that research, people that are missed are oftentimes people who are polysubstance users, especially stimulant users, which I know both Oregon and Colorado have a significant population of stimulant users. And there's the concern, of course, for cross-contamination and adulteration of stimulants with opioids. But also, people who use stimulants are wonderful first responders because they're typically not using opioids, right? So I really love the thought of arming stimulant users with naloxone so that they can respond, to overdoses. But we do a lot of that work with a quality improvement lens in states. And what I like to say too is there's really good evidence, very compelling evidence that if you want to have really effective naloxone distribution systems, use harm reduction, use justice involved populations. And the thing that people often miss is you use hospitals and healthcare spaces. Because there's a Delaware did this large kind of review of all their overdoses in their state. Very nice, very small state, very easy to get all the numbers and all the hospitals, right? But what they found is like the people who had an overdose death, it's around 60% of them were seen in an emergency department in the year or 2 years prior to their death, right? So there was a 60% chance that we could have intervened in some of those fatalities if we had the correct system in place to identify and distribute naloxone. For EMS agencies, which we do a ton of work with EMS too, there's also really compelling data about EMS leave behind programs. And the fact that EMS, especially in our current day, is seeing far, far more declinations of transport to hospitals. So in city and county of Denver, which we serve all our first responders with naloxone, it's around a 67% post-overdose declining transport to definitive care. So if you can imagine that, wow, almost 70% of people don't go to the hospital. Where do we have to intervene? The answer is we have to intervene much, much greater upstream with our EMS and first responders in many of those cases. So yeah, it's sorry, and I see there has a hand up. I get very excited when I talk about naloxone, so I apologize if I go on a lot of different tangents.
No, this is great. We're loving it, and I do see Haven, who also loves naloxone. So Haven, go ahead. You're meeting your match, Dr. Stater.
It's not a competition. It is we are all on the same team here. But yes, I'm a little excited about naloxone. I'm curious in the creation of legislation. Did you just add, like, explicitly amend your naloxone access bill to include just add on including expired overdose reversal products?
Almost every bill that we've ever collaborated on with our legislator has been pitching the idea to the legislator saying yes, the legislator then going to their bill writer pulling all the existing legislation, and then us deciding if this is a totally new statute or if this is something that there's already statute that needs to be amended for. And my guess is that you're probably going to do a statute amendment where you have statute around, Good Samaritan, distribution, et cetera. And you're just going to need to pull that and add that expired naloxone clause. I find this very helpful, and I've noticed this in some legislation and outside of others. But for hospitals and healthcare settings in particular, which are much more risk adverse, I love calling hospitals and medical spaces out explicitly in your bill, because that will add to the comfort of your medical spaces in distributing when they're explicitly called out as having legal protections against civil and criminal liability.
And I'm like 90% sure our naloxone, we've amended our naloxone. It first passed in 2013, and we've, I think, amended it like 8 times since then to like the initial bill was not what I wanted it to be. It's much closer to what I want it to be now. And I believe we actually do call out in there healthcare settings for naloxone distribution. Okay. I would have to double check that. Just for this group, if we are thinking about pursuing this, I think it could be an easier change.
We also have, just while you're on that vein, we do have a document that we're about to publish because most state houses, I should say, are closing their legislative session. And this is when we start jockeying for new bills in the next one. So we actually have a full compendium of suggested naloxone legislation that covers school-based, like it's got 5 or 6 high priority items, and covers everything from education to costs and naloxone, and we're happy to share that. We're just putting the final touches on that, and it's a nice playbook, including collected legislation from across the country, kind of a latest and greatest of 2026 naloxone legislation. Because it's much easier for us to pass bills when sometimes there's precedent from other, for other legislators.
We definitely would love to see the playbook. Haven, were you going to add something else?
I don't think so.
Okay. Thought I saw you come off mute. I'm just circling through to see if there are any other hands or questions. This computer's a little bit wonky, so if you have your hand up, feel free to also just say.
Well, I have I guess an ask of you guys, which is, one, Naloxone Project's always happy as a nonprofit to come and chat through all these things. If you love naloxone as much as it sounds like you love naloxone, we also invite people to start a chapter, the Oregon Naloxone Project. Sometimes those chapters help be the tip of the spear. Sometimes all there is just a way to share the latest and greatest with other colleagues across the country that are trying to do the same type of work. So my plug would be, I would love to have an Oregon Naloxone chapter, and I also have some Oregon roots. The first job I actually took out of residency was in Salem, Oregon, with Salem Emergency Physicians. So I have a lot of fond memories of my time in Oregon, except for the winters. Let's just be honest, the winters in Oregon suck.
The rain.
At least that was my opinion.
Yeah, you really have to get used to the rain here. Yeah, if you want to send that information along with your other materials, that would be great.
Sounds great.
And then I heard you say that you shared that you have a playbook for the legislative portions. Do you have any other playbooks or kind of like recommended toolkits that you share that we can take a little peek at? Or maybe they're just on the website. We can do it that way too.
Yeah, we do. We do a lot of medical space stuff. So our current existing programs are ED programs, labor and delivery programs to address maternal overdose. So that's been very popular, and we've helped a lot of states stand up L&D distribution. We do a lot in pre-hospital. That's called our pre-hospital addiction care consortium. We also do trainings on like how to initiate buprenorphine and connect to care. So we do a lot of buprenorphine work in a pre-hospital setting. And then our most recent one is Response, which is a school-based thing, meaning I think most states don't have good legislation around educating youth and don't have that in education statutes. And then also having really intelligent legislation where youth can not only access naloxone, carry naloxone in schools, have legal protections for administration, but then also where schools can distribute naloxone to at-risk families. Because a lot of, we know that a lot of youth actually have, family members, sometimes parents that struggle with substance use. And we want to make sure that they are able to access naloxone and be empowered if they are in a difficult situation where they might come home to a parent who is overdosed, right? So there's a lot in that youth space that I think we can create really intelligent policy on as well. Nikki, am I forgetting anything? Oh yeah, we do a lot of workforce stuff too. Nikki's the queen of naloxone workforce stuff. So getting to high-risk workforces, especially construction, oil trades, right? We do a lot of work in that space. And the final thing that we really love is working with states on naloxone cost and access. What we find is that a lot of people spend like idiots on naloxone. They're paying $10, $15 more than they need to pay for naloxone, and then saying that they run out of naloxone too soon. So we're very passionate about naloxone sustainability and trying to incorporate that not just into grant programs, right, which are very unstable, but trying to put those on more bedrock foundational programs such as insurers or in-state budgets. So.
Great, thank you. And it looks like Nikki's going to send us all the information. Haven, your hand's up. Go ahead.
Yeah, just one more quick question. I anticipate Oregon is more risk averse than you would think it is sometimes around all kinds of things. And I'm curious if you just blanketed said all expired naloxone, even though most of the research is much shorter than that.
Yep.
And full disclosure, carry expired naloxone, use expired naloxone, not scared of expired naloxone.
Yeah.
We'll accept short-sided naloxone to get out to the community. But have you seen any pushback around just blanket expired naloxone is fine? Whereas
not in my home state, and in our home state, I think we're a big enough group that people defer to us when it comes to naloxone policy and regs. I have seen other states start passing more limited bills. Maryland, for example, wanted just a 1-year extension. I think Utah had 2 years, right? And I think a lot of those too, by the way, when I got to asking how, a lot of those are pushed by manufacturers too, right? Of saying, okay, well, we see the evidence and we want this to just be a little bit more shorted. So my own inkling says, my own preference is to make it vague in that respect. But I do 100% acknowledge that there's a lot of states that want to be more conservative. And I think that anything passed in this thing is a benefit, right? If you add a year or 2 years to all your naloxone, that's wonderful. But I think that if you were to ask me what should we pass, I'd say, well, what happens to all the medical legal protections? Well, then a good intended citizen or group not realize that their naloxone was 3 years expired when it should have been 2 years expired. And then will that now create medical legal consequence for groups, et cetera? So again, I think that once you start putting these rough frame lines, they increase the amount of kind of sticky, well, what if questions. Whereas I think that the evidence is at least there's one study that says 30 years, right? The evidence there says that we should be a little bit more less prescriptive with it, is what I'd say.
thank you.
That's my own personal, not naloxone product. This is Don's own personal philosophy on how I would pass that bill. Okay, friends, I have an 11 o'clock too, so I'm going to say adieu to all of you. Thank you so much for your time. I hope
Thank you
that
so
it's
much.
beneficial. Thank you for all the things that you do as well. You take care.
Thanks. Take care.
Just to follow up, I do have to jump off as well. So please email me with any questions, but I will also include, Haven, several different bills that have different versions of languages so that you could see what options are out there. Even some bills that are in draft mode that are being sent over. All right. Thank you all.
Thanks for joining us.
Okay. Bye-bye.
All right, great conversation. Thanks for all the questions and looking forward to seeing the information that they share back with us. Mara, I don't have the agenda up on my side. We're going to transition to some conversation around
Yeah.
toolkit?
We are gonna do a quick jump back in time, and Annalise is gonna give us some directors updates first and foremost.
That's
And-
right. Thank you.
Yeah, and I will be very quick here because I don't want to interrupt the flow. One of my updates from other committees I do want to share, the treatment committee. Folks might remember that they're really focused on initial access to care, transition throughout care, and evidence-based practices. And they started a conversation last month about developing a provider survey. So I just want to put that out there to all of you, especially in the context of this conversation. And we haven't talked about timing, but maybe the next couple of months, we might be coming back to all of you to think about what are a few questions specific to health and safety interventions, probably specific to naloxone is what I'm thinking that you all would like answered in that. So we're still kind of scoping that out, but just wanted to give folks that heads up. Recovery has been really focused on recovery community centers. And actually the newsletter from last Friday talks about the definition that they've come up with and a summit that they held down at Seaside before Peermageddon. No, Peerpocalypse. Sorry, I'm getting the peer conferences confused these days. Prevention continues to talk about their Center for Excellence. Oh yeah, also put forward some recommendations that they're doing in conjunction with the recovery committee related to recovery spaces and recovery community centers, particular to youth. And then the full commission spent most of our time last month, and we'll be spending a lot of time in June talking about interim measures. So that's another thing to keep in the back of your head. You know, we always talk about our big three: reducing prevalence, deaths, and disparities. But you all came up with your near-term measures, and a lot of it is kind of like deliverables, right? Like creating a toolkit, doing an analysis. So really thinking about what those interim metrics are going to be that we are measuring across the continuum of care. So that is my very quick update. As always, happy to answer any questions, but don't want to interrupt your flow.
Thank you, Annalise. Are there questions?
I was just going to ask sorry, I always have questions.
That's great.
When you say provider survey, what kind, like who's the intended audience for that survey?
So they are still defining that scope, but very much like clinical treatment providers. And so where they're thinking about maybe getting a little bit bigger is like, what do we want to do in terms of like outpatient, right? Are we going to survey every single outpatient provider? Do we want to start to push into primary care? Those kinds of questions. Not so much, you know, peer service providers, or if you're, you know, a comprehensive harm reduction services organization, you know, probably not so much in that respect. And then at the other end, some of you know, under House Bill 3321, we're doing a whole bunch of primary prevention, upstream prevention surveys right now too. So some more information that might give us some models going forward to kind of fill in across the continuum of care and how to gather information.
Thank you. Any other questions? Okay. Thank you, Annalise. We are now going to review a visual that Mara put together that's trying to kind of show us the different concerns and solutions that we have come up with so far based upon this group's conversation. So I'll hand it over to you, Mara.
Great. Thank you, Stacy. So, in trying to map all of this was something that I have looked at in many different formats. I sort of wanted to go from like, where does naloxone come from and where does it end up? And what is in the way of getting it into the hands of people who need it and want it? So sort of when in the past when we've had these conversations, I thought about this as like upstream and downstream. So like where does naloxone come from is upstream, and then where does it end up is downstream. And in this visual, now we have barriers as boulders that are keeping the flow of the stream from going through. But when I really looked at this, I started really thinking about how it doesn't actually look like this. And it looks, in fact, the opposite. So, uh, Ashley, can you go to the next slide? And this was sort of like in my brain. We start with like a lot of access to naloxone up here. And what I've been hearing you say over the last 2 years is that it really is like a trickle and not like the flow of naloxone that we would like to see going directly from the manufacturers or from Save Lives Oregon or directly from MCAP or anywhere and directly into the hands of people who use drugs, which is my understanding from y'all that you have taught me is sort of like gold standard. Like this is what we're hoping for. So in this visual, you can see that it starts with where does it come from in the state. So MCAP, which we talked to Kim, right, directly from MCAP, and Save Lives Oregon, which is also MCAP. People also report acquiring naloxone from national alliances, direct from the manufacturer, from Amazon, National Harm Reduction Alliances as well. And so the question that we, in looking at the budget that we have, or the financial analysis that we've done, we don't have all of that just yet. But in looking at that, I sort of looked at in 23-25, the biennium, we spent at least $12 million on naloxone in the state, at least. And that's just from what I can see based on the spending from MCAP and from Save Lives Oregon and a couple of different agencies at the agency level. So I guess the question here then becomes, did all of that get into the hands of people who use drugs? And I think what I've heard from you, based on the barriers that we have listed here, is that no, it didn't. And so where are the barriers and where can we reach in and try and like move some of these things around? I'm seeing all of these things as a potential place to intervene. And so we've looked at, we're talking about expired naloxone right now. In our conversations, we've talked about it being kept in inaccessible spots or like it's just sitting in a building and not necessarily like in the hands of people who need it the most. We've talked about lack of distribution networks. We've talked about lack of data. We've talked about lack of education, lack of clear guidance. We've talked about stigma. We've talked about all of these barriers that are in place. And then, so we have talked through all these barriers. Sorry, I lost my notes. So when we are talking specifically about all of these things, Stacy came up with this idea, and I mean, this is something that I think we've been working towards specifically, is like a toolkit of resources that can provide clear guidance on what resources are available, to whom, clarifications on statutes, best practices, and trusted resources. We can write policy briefs. We can update existing resources. There are all sorts of things that we can do to reach into this stream and to like change the flow in whatever way. And I think the expired naloxone conversation is a really good opportunity for us to like see this in action. Because of what Dr. Stater and Nikki just shared with us about like the national context. And then Dr. Present is going to come talk to us in a little bit about sort of like the Oregon context. Are we, more interested in another group bringing a legislative concept to change the rules? Is there going to be like Board of Pharmacy stuff that would be easier, or like a policy to clarify rather than that? Is it like a connection to local resources issue, or is it a policy problem kind of thing? So I think I'm hoping that this brings some things up for folks and I can clarify anything that is not clear. And if this is bringing something up to for folks, I would love to be able to hear it and take some notes and see if there's uh, anything that we can move forward with. Stacey.
Yeah. Well, just because are there any reactions to this visual that Mara is sharing?
I'm just curious if this is what you think is happening in 2026, if this was prior to Save Lives Oregon starting up. It doesn't feel accurate for 2026 to me.
Can you share more a little about what you're seeing here, Blue?
Well, I definitely like some of them make sense. I'm just curious about like the lack of education. Is it specifically because it's about naloxone and not expired naloxone? I know that Save Lives Oregon has a lot of fact sheets, has done a lot of trainings, as well as, you know, a lot of other organizations. It just feels there's a lot of data. I know Save Lives Oregon collects a lot of data around how much naloxone is being given out, how many organizations they have. It just feels a little different from my personal experience.
Thank you, Blue. Any other reactions or first reactions to this?
Yeah, I guess I'll just speak to that a little bit as well, just kind of connecting with some of what Blue mentioned. You know, as a community-based organization, not only do we want to understand state level happenings around naloxone and also have worked hard to be a part of that, but also when it comes to stigma, law enforcement, expired naloxone, first responders, and leave behind programs, pharmacies, I feel like there's so many more connecting points in Oregon that we have utilized in building the network. There is still some inefficiencies within the communication in those networks on the larger scale when it comes to distribution. But I do feel like we have come a long way from where we were at in the network of the way that we're responding with all different levels of distributing naloxone and the people who might, I don't want to say touch, but interact with overdose just in general.
Thanks, Serafina.
I'll say something, I guess. Can you guys hear me okay?
Yeah, thanks, Eric.
Okay, yeah, I mean, I was just thinking like places I've seen naloxone being distributed over the past like couple of years, the libraries, the food pantries, I mean, just like places you would not historically see it. I mean, obviously like the syringe exchange, places that would be like historically where they would pass it out, you know, like maybe homeless outreach agencies, but I've also seen it just like kind of popping up all over. Even my youngest son, high school, had like a whole thing on it in St. Helens a few like last year about opioid safety, which I thought was pretty impressive for a high school, So I mean I do think that there's been so many deaths in Oregon. I think that just so many more agencies are aware of what's happening. They've kind of stepped this up in a lot of ways. I mean, I like the visual though, but I just think that stuff still exists. I think stigma still exists. I think that for the like majority of the population who don't have any connection to, addiction at all, like this is obviously going to still be a thing. But I definitely think it's getting out more now than it used to, at least from my experience. I mean, that's obviously a smaller view of experience in the world.
Thank you. Adam.
Hey, good morning. So I had a couple things. First of all, I love the slide. I love what it's addressing. But Blue had a comment in there earlier in the chat people without substance use disorders are also at risk of overdose. So I kind of wanted to piggyback on that because I feel like, working in medication assisted treatment with folks with OUD for, 10 plus years, I feel like most of those folks are either carried naloxone, know where to get it. So piggybacking on Blue's comment, I mean, to me, it's if we're letting the naloxone expire, that's an issue. Why? Um, let's get it to the folks. Let's get it to the parents whose kids go to school, and maybe there's a batch of pressed pills going around in school, so the kids take it. I think there's other ways to utilize it. And it being expired, I mean, that's a problem. And I love this analogy, but I also love the Blue's comment. I've done trainings with union companies at big union events on naloxone, and they're like, "Man, we need this. We have overdoses in our plants and this and that. Or at lunch in the parking lot." So I feel like there's other avenues, that we can break this up. So anyway, just my 2 cents. Thank you.
That's helpful. Thank you. One of the things I love about a visual is it helps us to kind of, I think, get on the same page and make sure we're all using the same words and have the same understanding of what we're doing. So the fact that like this isn't quite fitting is super helpful. So that's great. Thank you for the feedback and the reflections. And it's pretty clear that one of the pieces that is at least not maybe reflected on this visual is the population who will be using naloxone to support someone who's overdosing. So I think we can make sure to articulate that differently in this visual. One of the comments I heard, if I just can ask a quick question, was around just the understanding of, thanks, Blue. Your great comments in the chat. Thank you. Was the comments around like, is this representative of 2026 or moving forward? What would you add to this, to a visual, whether it's this visual or maybe a flow chart? Crescencia, that's a good idea. What would you add or even take away in terms of the places to focus on in 2027, or what feels most important?
And if I can maybe put a finer point on it, it feels like this conversation has evolved a little bit in the past year, because I will say, when we were developing the plan, we heard a lot that we really need to focus on getting naloxone into hands of drug users. We shouldn't be focusing so broadly. And now it sounds like, and maybe it was because there was an increased funding in Save Lives Oregon. Although I do want to emphasize Save Lives Oregon is not the only payer in the state. So maybe something has changed in the past year, like we made progress as we were making the plan. So, like, what are the points that need to be refined, perhaps? Like, I heard a little pushback on lack of data, but I heard really strongly when we were developing the plan that folks don't know how it's being distributed. And it sounds like maybe there's a problem there since we're now sitting on a bunch of expired naloxone. So maybe folks can think about like what's changed in the past year and how that affects this.
Lou, I see your comment, and do you want to say more, or just leave it in the chat?
I'm just trying to respect the time. I'm pretty sure we're gonna run out of time for some of what we have later. But I do I mean, I know that anyone that gets naloxone from Save Lives Oregon reports monthly. So I think that if we could look at that data maybe in a future meeting, I think that might be helpful for our group. I know it's not the only place people get naloxone, but certainly a lot of organizations are getting naloxone through there.
Okay, so maybe one takeaway, an action item, thank you, Blue, would be to review the data that we do have and see what's missing. In the past several meetings, I think there's been a piece around like, I'm not going to get this exactly right, but maybe for other agencies that are not getting naloxone from Save Lives Oregon, having some sort of a recommendation on what data they do collect, so we have a better understanding of the populations they're serving. So I think maybe looking at the current data from Save Lives Oregon would be helpful. So I'm reading the chat. There's also maybe some information around a request around where Narcan is being held and is expiring. So having more of an understanding, like where in the state is it actually expiring, and targeting potentially those agencies with education for those specific areas. Crescencia, you're putting your hand up and I'm trying to articulate your wonderful idea. Would you mind?
Oh, I have another idea.
Okay.
So I was thinking, could we ask individuals, like organizations that are receiving Narcan distributions from state entities, that they have to report the expiration dates, and then like maybe to help distribute them, like, okay, so at the 8-month mark, if you have this excess of naloxone, it needs to be given to, for instance, like my harm reduction program, which I know is going to get into the hands of the individuals that are using it. Does that? Yeah. Okay.
Absolutely. Some sort of an intervention at a certain time frame to help people to understand I have this much left. I also, we are getting close to when Dr. President is going to start presenting. So one piece that I'm kind of circling around also is like, are we on the same page of the current problem that we're trying to solve? And we're having a lot of conversation right now about the, what to do with expired naloxone. Which makes a lot of sense because we had 2 presenters on that today. And so maybe we need to have a visual that's specific to that, to the expired naloxone, the process of what to do, and the recommendations related to expired naloxone. Are there any last minute thoughts on this slide, or questions, concerns? And maybe some suggestions also on what you'd like to see differently? Go ahead, Blue.
Well, I know people who use drugs is at the bottom, but I do think that they are part of secondary distribution, and maybe should also be put somewhere in that higher up, because we do utilize people who use drugs as secondary responders. I mean, secondary distributors, and we'll give them more to distribute to their peers. It's a very effective way to get more naloxone into the hands of people who need it the most.
Thank you, Blue. And Dharma?
Yeah, I have a similar comment to Blues, but I also was thinking about how if we're gonna resolve the risk with the distribution of the expired naloxone, how does that get reincorporated in the data for like a gaps analysis for like, missing doses out to people, right? Like, are we reincorporating that data back in for the expired doses to account for that? Like, I guess that's just my thought on like how we're examining those metrics.
Thank you. Annalise or Mara, do you have any last comments before we transition to Dr. President?
I think I just have have a quick question because I want to make sure that because sometimes I walk away from these committee meetings with something, that is not what you all intend. What I'm hearing is the urgency around naloxone because a year ago it was we need more naloxone, we need more naloxone, we need millions and millions and millions of dollars of naloxone. It doesn't sound like that's the case. Clearly, we need to figure out why we're sitting on expired naloxone if we were saying that a year ago. Does anything change if Save Lives Oregon has less resources? And do I have the right impression?
My gut is 100% it changes if Save Lives Oregon runs out of funding. Like the vast majority of programs, like I can name multiple programs, and I'm sure Jude has numbers on this that say I wouldn't be able to give out naloxone if not for like the only naloxone we get is from Save Lives Oregon. So yeah, I think, and I saw how many programs that historically would never think about doing naloxone started doing naloxone once they were able to access those funds. So I think 100% it plays a major role.
Yeah,
Thanks,
I would
Kevin.
just piggyback off of Haven and say absolutely. Save Lives Oregon has specifically looked at people who are actively using drugs, those that need naloxone most, and are able to help those that are being affected daily. And as Blue mentioned, being those secondary responders, we know that lives have been saved through that work that otherwise would not be. I also want to bring to the table, I know we do have some issues still around expired naloxone sitting around when it shouldn't be. But I also have received so much feedback from our community-based organizations, but also individuals who have gotten naloxone and wanted to be prepared and had that expired naloxone and had no idea what to do with it. And I can't tell you how many times they've come to us and say, this is expired. Oftentimes, we've given the same recommendations that our wonderful doctor gave in that it's still incredibly effective. And with the high potency, we don't know how many doses are going to need to be used. So we'll give them a new naloxone kit, but oftentimes I'll recommend if they feel comfortable using it still to have that expired as a backup. Now, we also utilize expired naloxone and naloxone that's been like extremely affected in our nalox boxes by, higher low temperatures for our trainings. To really provide that hands-on education and allow people to see the pressure behind the plunger, how you can't use the plunger again once you've used it once, right? And so just bringing that to the surface as we have these discussions as well.
Thank you. I guess I'm thinking there is still, I think, pretty clear a desire for more understanding of what to do with expired naloxone. Where is it? What does the data say? Where are the specific recommendations? Any legislative pieces? So I'm kind of doing that out of order, but there does seem to be this need to still really flush that out. So I think that's a piece for us to take away. That's great. Also, Annalise, to your question, clear feedback that things would change if Save Lives Oregon's funding shifted. So that was very helpful from everyone. Thank you very much. This is great. The feedback is really helpful in terms of where to move next. So some deliverables that I'm hearing, some key pieces are Save Lives Oregon funding has to stay the same. We don't want to lose it. Dr. President's not on yet. Okay. There was a request around that, acknowledging that we do have a lot more data around from Save Lives Oregon. So I think getting more clear on what we do have from them that can then help us to understand, are there any gaps that we want to fill? And then a workflow for expired naloxone appears to be a really big need still. And then ensuring that we're infusing people who use drugs throughout this visual in terms of handing out naloxone. Those are some clear pieces that I've heard so far. Crescencia, go ahead.
I apologize. I joined late, but I know I missed some valuable information. it sounds like you guys might have been talking about the expiration dates on naloxone. Is that accurate?
We had a presentation from a doctor in Colorado who has a naloxone project focusing on expired naloxone.
Um, I was wondering, did we get any data that we can create into like a PDF or like a packet or information? If anybody can share any of the information they received earlier in the meeting, I would
We'll
love to
send
create something to share with my clients and other team members. So thank you so
Absolutely.
much.
We'll send those slides out. And I think, you're saying very similar to what Haven's saying in the chat, which is like some sort of an educational campaign on naloxone would be helpful for lots of different communities, organizations. I think it might be useful for us to talk a little bit about what would be in an educational campaign, since we've all kind of agreed that would be of use. And obviously it would be different based upon who the campaign was for. But can we have a little conversation about who or what would be useful to have in a education campaign? Are there pieces on this slide that would be helpful? So would data be helpful to have in the campaign? We have a couple more minutes on this topic.
My personal bias and
Mhm.
thoughts and ideas would be like educating people that have naloxone on how to distribute short dated, like even if we don't change to expired, even short dated, right? Like the idea that a fire department might have 3 boxes of naloxone sitting expiring in whatever time frame, and making sure they know how to get that to someone who can distribute it, right?
Okay.
And that will be able to move it, I think would be really helpful, right? Like, for example, because we have a pharmacy, I do not distribute expired naloxone. That said, I know who does, and I can make sure we can like move naloxone that it, and so, and I know that that's not true everywhere across the state, but I honestly think when I think about who is sitting on naloxone, it's not harm reduction programs, it's not addiction providers, it's going to be like schools that have 4 naloxone kits on their campus that they aren't using necessarily, and then it goes bad, right?
We had this
That would
at
be my
Oregon
guess.
last year. They didn't know what to do with the naloxone that was at the front desk that was short dated. So that's a really great point. So I guess I'm also, and of course, Dr. President is now here. So I think that I'm also hearing kind of 2 different toolkits and even some definitions around what's short dated, expiring to places like fire departments, administrative places, and then also a process for expired. Those seem like 2 very like specific kind of actions that we could take. So I think what I would like to suggest is that we come back in the next meeting with kind of those lined out, maybe some recommendations there and a visual for those 2 areas, so we can get a little bit more clear on what to do and recommendations related to the expired or short dated naloxone. Mara, how are you feeling about this conversation? Is there anything else that you would like to ask for before we move on to Dr. President?
No, I don't think so. I think I have got a lot of good notes, and I will try another way to get this information across the next time. So
Yep,
thank
that's
you all.
great. Okay. And then Blue, I see your comment in the chat. That's helpful in terms of like some sort of a toolkit or process for expired or short dated. Excellent. Dr. President, are you here?
I am here. Hi, everybody.
Hi, nice to see you, Sarah.
Nice to see you too.
Are you ready to present for us, or do you need a minute?
So, I
Or a conversation? Is that maybe what
maybe
you're
need a
going to say?
conversation. So I had a conversation with Mara and a few other folks from CODA and the Naloxone Project, which is focused or started in Colorado, around sort of opportunities for use of expired naloxone within state law. So I think Mara had asked if I would come and chat with you guys a little bit. And I'm sorry, I've just missed the conversation you've had. So you may have addressed a lot of what I'm thinking about.
Can you also just introduce yourself
Absolutely.
so
Yeah.
everyone
Hi,
knows
everybody.
who you
I'm
are and how brilliant you are? Thanks so much.
Sarah Present. I am the health officer for Clackamas County. I'm a family medicine doctor and a preventive medicine doctor. I also work part-time in primary care at the Clackamas County Health Centers at Beaver Creek. So I have I have my own patient panel and do primary care there. And I've been with Clackamas for 14 years. So have been, involved in a lot of the sort of opioid prevention work from prescribing guideline rollout to naloxone expansion and over-the-counter work. So I've seen how expansion of access to naloxone has worked in a few different ways, both through like public interest and through legislation and through rule change. And so there's a lot there. Maybe I can ask Mara if you have any specific things you want me to chat about.
Thanks, Sarah.
Yeah, I was hoping, so when we had a conversation with the Naloxone Project, there was some discussion about, what has worked in other states. And earlier on, Dr. Stater came and talked to us earlier on in this meeting, and he talked a little bit about some other states and what has been done like legislatively. But when we had a conversation, there was you provided some like really great context for the state of Oregon in regards to expired naloxone, and so I think I know I would really appreciate sharing that with the rest of the group of sort of like what avenues are there? Is legislation, the only way? Like I know that you had mentioned some like rule changes for Board of Pharmacy or other ways to go about this if legislation isn't the way. So I would love to hear your perspective from your years of experience and like how expired naloxone fits into like the policy landscape in Oregon.
Yeah, thanks. So, through legislative concept and successful legislation, kind of bystander use of naloxone has been really successful in Oregon. And through sort of a pharmacy type rule change, we can also have a standing order from the state health officer that allows for distribution of naloxone to organizations that can use it through bystander use, right? So you don't have to get a prescription from a physician or from your local health officer. It can be from the state, and that has allowed for state supply distribution as well. And so we can, go through the clearinghouse, which is through OHA, and every county can have access to getting naloxone, regardless of their local health officer or local physicians sort of writing an order for that. So that was kind of a combination of a statewide standing order and legislative action that really protects bystander use of naloxone. And I think Oregon's been incredibly successful in naloxone distribution, successful in sort of advocating for lower. I think the cost that we're getting for intranasal naloxone in Oregon is as low as any state is able to with the manufacturer. And that comes from, good action at a number of levels. I think when we look at medication expiration dates, and like Dr. Strader in our meeting talked a lot about this, it goes beyond us, right? It's a really challenging thing where the way that pharmaceuticals are approved is based on an expiration date that the manufacturer submits to the FDA. So it's not necessarily science-based on when the medications actually expire. It's based on when the manufacturer says that their expiration date is. And shorter expiration dates lead to more sales, basically, right? And there's not a lot of room for FDA to impose longer expiration dates, even if we know that the medications work. So it's sort of a system-wide challenge. The agriculture is the same with food. Food expiration dates are kind of are not necessarily based on the science of when that food actually expires. So there's some sort of questions I have around legislation around expired naloxone versus the use of other expired medications that can have helpful sort of public health emergency response needs. So we were talking about like oseltamivir for flu outbreaks or novel influenza. We know that oseltamivir stored in the right conditions lasts 20 years longer than at least similar to naloxone. And oseltamivir is Tamiflu. It's an anti-flu, antiviral agent. So I've had thoughts about whether, which can be used in an emergency use situation for a board of pharmacy, right? So like naloxone, if we declare an emergency, we can use expired naloxone for emergency use, but you have to have this very complicated emergency use authorization. I get what I'm getting to is I think that there are potential for rule changes within the board of pharmacy that I have not had quite the avenues to explore, but those are some of the things that I've been thinking about and talking with our state health officer on whether those are avenues, so that the focus on naloxone doesn't sort of overshadow some needs for other things as well, right? Is there something that we could do that could help a lot of other public health issues at the same time? At the same time, getting momentum and education around expired meds sometimes does take the legislative route need to sort of push us to have those conversations more. So those are kind of the things I was bringing up, Mara. I'm not sure if people have questions. I'm looking at the chat. Exactly. So in our questions around whether we can, as a county health department, distribute our expired medications as a community health pharmacy, no, we cannot. Community-based organizations, as long as you are not some specific places that are listed in pharmacy rule, which includes schools and child, like foster home, I'm sorry, I don't have it all, but recovery centers or youth housing. Those specifically cannot use expired medications, but many other community-based organizations, there's no rule excluding the use of expired medications or the distribution of it to people. So that's, I think, maybe what you guys were already talking about a little bit. Haven, you were saying you guys can't do it, but you know who can. So like making sure that before we make any legislative action or push for a board of pharmacy rule change, which has its own complications, there's a lot that can be done sort of in educating ourselves around the fact that expired naloxone does still work for many, many years after expiration date. I don't know if that's helpful. I feel like I just rambled for a bit.
No, I think that's super helpful. Thank you. I think we were looking at sort of like the universe of expired naloxone legislation and things like that with Dr. Stater. We sort of just like dipped our toe into that. And then I was sort of hoping that like this, we could like bring it back down and say like, now we're specifically talking about Oregon. So let me just put something out here. So like what we've sort of been talking around in this and what Serafina just put in the chat is like, my question now is, after we've had this discussion about expired naloxone, is this a policy problem or is this a like community connections problem? Is this like something that people just don't know that they can give their expired naloxone to a harm reduction organization in their area? Or is this a policy problem? Is this like change board of pharmacy rules legislative concept situation?
I think it depends on the target, to be honest. Like I could see nonprofits being willing to take naloxone and distribute expired naloxone. I don't see an emergency room being comfortable with that unless it's written into legislation. You know what I mean? Like, right. So I think it really depends on the scope of what we're trying to do. Again, I think we are a pretty risk averse state. And I think local health departments are going to want it in writing that it's fine, right? That's my gut.
And in Colorado, they did successfully pass legislation very specifically around naloxone, and places around the country will send them, and they can distribute it from the emergency room, is my understanding, because it's really clearly stated. I think that thinking about this as far as, as far as the clearinghouse and how we get it and the costs of it, being able to safely use the naloxone that is out there now, rather than having to spend money that none of our organizations have to purchase new naloxone when we have naloxone that works already, is an important factor. I think just the funding of it is, or the cost of it is something that makes it a big conversation right now, right? And counties would certainly love to be able to have it in writing, somehow legally approved, that we can continue to distribute it.
Sarah, you mentioned in thinking about like if we were going to extend naloxone expiration dates, that other medications we should be considering other public, like as a public health nerd, like, is there a list? Like, can you, and this maybe is not a conversation for here, but like, if we are looking to do this for naloxone, I would love for it to be a way and a vector to like do things like other public health emergent responses, right? Because we know expiration dates are what they are. Can you think of other examples? I mean, you said flu, and maybe again, this is off topic and whatever, but I think that like if we are going to be thinking about this, creating the biggest public health impact is like a smart way to move this. I also think politically, being able to tie it to a public health response as opposed to drug use stuff and harm reduction politically is going to be more viable.
We can now use certain expired medications from like the Strategic National Stockpile after their expiration date in an emergency like if it's an emergency. So I think that seeing, and the SNS has a lot of post-exposure prophylaxis medications that are frequently tested for their viability, which is why we can use oseltamivir that has expired already. I think that sort of doing a blanket without having to declare an emergency or saying this is an emergency situation, if it's a medication of public health importance for urgent use kind of thing, is a tricky legal thing, but I think could be really successful. And like you said, if we frame it as a public health need, it might have, rather than a drug use need, it might have more traction. Yeah. So I'm agreeing with you. And I don't have that list in my head, but there are, I do think that there's a fairly short list of post-exposure prophylaxis medications.
Thank you. Any other questions for Sarah? Serafina, thank you for these resources. Sounds like we're definitely getting clear on narrowing the focus to short date or expired naloxone and understanding more about how it can be dispensed, how it can be shared, and if there are policy changes, exactly where those need to happen. It sounds like really healthcare settings is maybe the place to focus versus CBOs or nonprofit organizations. So I like the idea of filtering a lot of the information that we heard today into kind of those two, the expired naloxone as like the larger umbrella, and then maybe some workflows from there. And when I say expired, I'm also meaning the short dated. I think we probably need to define both of those, because Haven, that point was really well stated earlier. So lots of thoughts I have right now, but I think this has been really helpful in terms of like helping us to focus on just that expired and short dated naloxone is a huge area of opportunity for this work group and creating some real clarity and toolkits around what we can and cannot do. We're almost to public comment. Are there any other concerns, questions that anyone would like to share? And does it sound like that is the correct track to be going towards in terms of the expired short dated naloxone clarification? Does that sound right? I'd love to hear, actually, I'd love to mostly hear if that does not sound right so that we can get on track if there's kind of some thoughts around like that's not really where we want to be focusing. Any concerns? My screen is a little different today. Looking at the impact in Oregon of the joint letter. Okay. Thank you, Blue. Great reminder about that letter. I have that noted down. I was saying my view is a little different today, so I have to kind of flip through to see if there are any questions. I don't see any questions. I don't see any concerns about kind of narrowing that focus with Blue's reminder here about the joint letter would also be helpful. Mara, anything else that you need in terms of like today or questions that you have?
I do not think so. I think this has given us a good direction of where to go. So I think we are golden.
Okay. Great. Anything else before we open for public comment? Actually, I'm realizing I'm a little early, but it still seems like we've kind of come to a nice pause in our conversation. Ashley, have you received any requests for public comment?
I have not received any.
Okay. Any other last questions for Sarah while we have her on the line or concerns before we end today? Okay. Another really useful and helpful meeting. Lots of great feedback, which really helps to narrow the focus. So thank you so much for that. And then we will make sure to get all the slides and the resources out. And maybe we can even capture all of the links in here, and then as we can send those notes in the notes to everyone so everyone has access, because there's a lot of really great information. Seraphina, you put a lot in here, so thank you for that. That's helpful. And I think we can end for today. Does that sound okay? Fantastic. See you all very soon.